Hello and welcome everyone. I am Autumn Lintz, the Education Manager at the Foundation. Thank you for joining our Answers from the Experts Q&A. We are very excited to have you here today. Before I introduce our wonderful panelists, I'd like to go over some housekeeping. Q&A, yes, that is the reason we are here. Please make sure you use the Q&A tool in the webinar to ask your questions. We will be recording this program and it will be available on the Foundation's YouTube channel within a few days. We would like to thank our individual donors and our funding partners for making programs like this possible. Upon conclusion of the webinar, there will be a survey that pops up on your screen as you exit. We would appreciate you taking the time to complete the survey. Now, I would like to share some information on our speakers. We have with us today Dr. Lesley Street, a specialty of hematology and oncology. She's a clinical hematologist with a subspecialty focus in lymphoma. Her clinical practice is broad and includes acute care, ambulatory general hematology, and consultative hematology. Complementing her subspecialty focus, Dr. Street's academic pursuits include quality improvement, clinical trials, and education. Her leadership roles include site lead for hematology at South Health Campus and lymphoma fellowship director. Dr. Jori Hardin is a clinical assistant professor in the Department of Dermatology at the University of Calgary. She has a special interest in cutaneous lymphoma and outreach dermatology. She recently returned from a 6-month sabbatical, traveling across the United States, learning from experts in the field of cutaneous lymphoma. A major highlight of her career has been her partnership with Dr. Lesley Street, establishing the Calgary Cutaneous Lymphoma Program. Dr. Hardin strives to provide compassionate care to all members of society in her roles as a clinician, educator, and researcher. Welcome, Dr. Street and Dr. Hardin. We are very happy to have you with us today.
Hello, thanks so much, Autumn, for having us. It's really an honor to be here today.
And welcome, Dr. Street.
Hello, Autumn, and thank you everyone for joining our webinar today. We look forward to meeting you.
All right, well, let's go ahead and get started with our first question. How often should I get scans to make sure that my MF hasn't spread into my organs?
I'll let Dr. Street answer this one.
Hi, everyone. The important thing about scans for mycosis fungoides is to first have your MF, we'll call it, adequately staged at first diagnosis. And our practice is to do staging investigations, which include CT scan imaging at a time that an individual is first diagnosed, and thereafter perform the scan if the clinical status is changing, if there are new lymph nodes on clinical examination, or if there's any new findings of organ dysfunction that need closer investigation. But we don't do routine surveillance scans for individuals with MF.
I would add also to maybe Dr. Street that in patients who have early stage disease, so very minimal cutaneous involvement, we don't generally do scans in them at baseline, and that it would sort of be a case-by-case presentation, and that scans are maybe not indicated for everyone at baseline.
All right, thank you very much for that. Let's go ahead and go on to our next question. With MF stage 1A, do some patients do well with NBUVB at lower amounts than the 2,000 millijoules that seems to be a standard goal? Is it really necessary to build 2,000? Build 2,000 seems really hard on my skin, fair skin that tans. I've only gotten up to 1,200 millijoules and even wonder if just 700 or 900 would be enough. So prior to answering this question, I do want to give our disclaimer that Dr. Street and Dr. Hardin are giving us their opinion based on what they have seen in their own practice. Please do not consider this a second opinion. You should always discuss treatments with your physician.
So thanks for the question. When we talk about phototherapy for mycosis fungoides or cutaneous T-cell lymphoma, NBUVB stands for narrowband UVB, and it's a type of phototherapy that has a very restricted wavelength. That's 311 nanometers. when we decide actually what amount of energy should be delivered to the patient, I don't look specifically at the amount of energy, so the joules or millijoules that's given. What we try to achieve is something called the minimal erythema dose, or the MED, and that is individual to the patient. So what we want after a dose of phototherapy is for 24 hours, you have minimally perceptible erythema. That means your skin is slightly pink or red just for 24 hours following your phototherapy. And that's really our target. And the longer that you go for phototherapy, the more energy you're able to tolerate until you achieve that MED, or minimal erythema dose. So really it's patient specific, and you do not want to be burning while you're in the phototherapy booth if you're trying to achieve a specific target of energy. I would say it's not so much the joules that matters, but more whether you're achieving that MED, and tailoring your treatment to achieve that without getting too much or burning while you're in the booth.
Okay, thank you. That was some really good information. Can you let me know what result I can obtain with Excimer laser or UVB for the face? Can I rid my face and eyelids from the MF? Which is safest with better results? I think we have quite a few phototherapy questions today.
Sure. I'm not a phototherapy expert, so I'll do my best to answer these questions. In Alberta, we don't actually have access to the Excimer laser, so it is not actually a modality that I used to, and I haven't studied it specifically in mycosis fungoides. It is actually even more targeted wavelength compared to narrowband UVB. I think it would be safe on the face, as would narrowband UVB, and I would imagine the results of the phototherapy would be similar between the two.
Okay, thank you. I'm only stage 1A for 3 years now, but I'm never 100% clear. Almost, and then a few more small ones pop up or older patches make a return. Is that a sign of being more likely to later advance to large cell transformation or progression to organs?
I think I can take this. So to have limited stage MF and have the appearance and reappearance of small lesions as described, so patches or little plaques, is the typical pattern for the vast majority of patients with mycosis fungoides. And in that scenario, we really focus on skin-directed therapy. The question was related to whether or not the frequent recurrence of the limited stage is a prediction of future advanced stage. I'd say no. We don't, with current knowledge, have a great predictive model to identify which patients may evolve to develop advanced stage mycosis fungoides or large cell transformation. The important thing is to have a close relationship with your cutaneous lymphoma provider. If you notice that there are changes in the appearance of your skin lesions, whereby if you used to have predominantly patches, for example, and you're developing a new tumor, for instance, that you bring that to the attention of the provider and consider a biopsy and see if that's representing a change in the histology, or in this case, as represented in the question, the large cell transformation. The person who submitted this inquiry must have been aware that when an individual has large cell transformation, that does impact on our treatment recommendations. And I'm sure we'll get into that later on in the webinar. So in summary, the appearance and disappearance of skin lesions is a typical pattern and isn't necessarily something to worry about, but rather identify times where there's changes in the appearance of the skin itself, and consider rebiopsy. And as well, further to the first question where we're talking about when would we do re-imaging, that would be a scenario as well. If there were new clinical lymphadenopathy or lymph nodes identified on exam, or unexplained organ dysfunction, that might be a time to consider more in-depth investigations to look for whether or not an individual's experienced advanced stage mycosis fungoides.
Well, thank you. That was a really great, thorough answer to that one question. So on our next one, I read ahead and a personal, I am actually going to Halifax in the end of August and taking a week-long vacation exploring Nova Scotia. So I was kind of excited to see the question about and having Halifax in it. I've been recently diagnosed with MF1A, 7% of my trunk area. I am starting PUVA treatments. I have to travel 2 hours away and stay in Halifax away from my babies 4 days a week. How long could this potentially take until remission? Could it be more than 6 months? And this is something that we hear quite a bit in questions relating to the phototherapy or the challenges of going to therapy treatment and how often you have to go.
Thanks for that question, and sorry that you have to travel remotely or from remote to access treatment. For those in the webinar that don't know what PUVA is a type of phototherapy where you actually ingest or take a pill that's a photosensitizer, and then half an hour to an hour or two later get exposed to UVA. That's the UVA part of PUVA. So the psoralen is the P with UVA. And unfortunately, with all treatments with cutaneous lymphoma, it takes a while to know that it's working. And whether or not somebody has remission or a durable remission is patient specific. So hard to know timelines, but I would prepare yourself for a 3-month at least kind of assessment of whether or not it's working. And then if PUVA is working, you might potentially, with the guidance of your physician, be able to decrease the number of times that you're going, or change to an alternate regimen that might be more conducive to being at home with your family. But I can definitely appreciate the challenges of living away from an important treatment modality for your disease.
I can just add to that. Yeah, I'm just really glad to hear this question, actually. I wasn't sure how many people who would join us on the webinar or within Canada or various places in the United States, but it is such an important consideration for considering treatment modalities that we consider the individual circumstance, and this question really portrays one of the challenges that many people have, whether it be access to PUVA, extracorporeal photophoresis, or even seeing a subspecialist who knows about the disease of cutaneous lymphoma. Many individuals have to travel a very far away, and that is just one of the natural challenges of living in such a geographically large country or countries here. And so I think it was a really important question, and make sure that those challenges that you are encountering are fully sort of voiced in front of your provider, because sometimes there are alternatives, as Dr. Hardin referenced. While PUVA as a skin-directed therapy method might be very helpful for some people with plaque stage MF, there may be other alternatives like some certain systemic therapies that may also be useful, whether it be interferon or retinoids, if it's just simply too challenging to travel such a long way away from your family.
Okay, thank you. And in a couple of questions, we actually have a question about a retinoid, so that's kind of perfect timing. Is there a test that can distinguish between cutaneous T-cell lymphoma and cutaneous pseudolymphoma drug reaction? Is the treatment the same for both?
So this maybe goes down to the heart of like how do we diagnose a cutaneous and I'll say T-cell lymphoma, although there's a lot of overlap with pseudolymphoma and cutaneous B-cell lymphomas. There is no one specific test, but it is kind of combining all the pieces. So the first piece would be the clinical picture. What does the patient look like? What do the lesions look like? Where are they located, etc. The second test that we look at is under the microscope. So just the architecture of the cells, the shape of the cells, the type of cells. Then the pathologist does special stains on the cells so they can tell us, are they B or T cells, and what type of B and T cells, and more specifically, some of the surface markers on those cells. And then the last and fourth piece is is this a clonal process? And what that means is in a malignancy, you have one type of cell that's reproducing over and over, and that's more commonly seen in a cancer or lymphoma compared to a pseudolymphoma. Pseudolymphoma can be very challenging because it can look very much clinically and histologically, parts 1, 2, and 3 of that sort of algorithm, like a true lymphoma. So it often takes more than one biopsy or several biopsies over time and several visits over time to differentiate. I would argue that the distinction is important because the treatment of a pseudolymphoma is different. And again, that depends on if it's a B or T cell pseudolymphoma. But pseudolymphoma, or another name for that sometimes, is cutaneous lymphoid hyperplasia, meaning not a true lymphoma, can be treated much more conservatively than if somebody has a true T or B cell lymphoma. So it's really a combination of a multitude of things, and then looking at those parameters more than once over time.
I would just add, thank you, Dr. Hardin, for that nice overview. I would just add to highlight how we structure our program here in Calgary. For cases like this, where it's hard to discriminate whether an individual has true lymphoma or pseudolymphoma, that really highlights, one, is why we work together as having both a dermatologist and a hematologist or oncologist assessing the patient. But as well, we work very closely with our colleagues in dermatopathology and hematopathology. And in fact, many challenging cases of patients' lymphoma or pseudolymphoma that we've encountered, we'll bring those cases for review and collaboration with our pathology colleagues to get more opinions other than just our own, because it can be very hard to discriminate. And as Dr. Hardin said, that the management is very different. And it's important for the patient too, to know if you have, real lymphoma versus a pseudolymphoma process. So it's important for scenarios like that you get the expert opinion of many people. And also a case of pseudolymphoma may be one that we would follow with time. While initially it might have appeared to be pseudolymphoma, over time another process may evolve, or a true lymphoma may evolve as well. And so we try to follow those patients closely when it's a bit of a gray area.
Okay, thank you. That was really a great, thorough answer, and talking about the multidisciplinary, to where having both physicians working with a patient, and we always advocate that the patients do that. Have you prescribed oral retinoids for early stage MF1A, 1B in addition to NBUVB treatments? Why and how long do you keep patients with good response on retinoid therapy? And reminder, this is based on the patients they have seen, and not specifically on the person asking the question. That Dr. Hart and Dr. Street have not seen your records. So this is just an opinion based on what they have seen in their own patients.
I'll start maybe and then pass it to Dr. Street if she has anything to add. So absolutely, we use oral retinoids quite a lot in early stage cutaneous lymphoma, especially when patients are finding either topical therapy cumbersome or almost bordering on too extensive to apply. And we use it in combination with phototherapy because there is, I think, synergy between those two modalities together. In Canada, we are a little bit unlucky because we don't have access to the oral retinoid agent that has FDA approval and is used widely in the United States and Europe for cutaneous lymphoma. It's called bexarotene. So we can't access that here. So we've tried to make do with some of the other retinoids that we have, such as the isotretinoin family, the seriatine or acitretin, and then more recently, alitretinoin, which has, I would say, slightly better but less efficacy than bexarotene specifically. So the type of retinoid, I think, matters, and we do the best that we have. And then, yes, using it in combination with phototherapy, I think, is very useful. In terms of the duration of treatment, Often in cutaneous lymphoma, the goal is to achieve a durable response. And then if patients are doing well, then we hold the course. It would be rare, I think, in somebody that I would stop treatment or stop the retinoid if their disease was responding to that course of treatment. We know the natural history over time is for early stage disease to grumble. And that we don't have a cure. So in patients that are doing well and tolerating the treatment, I would maintain them on that unless there was an indication otherwise to change or stop treatment.
I would just add a couple of additional points to Dr. Hardin's summary, just about the tolerance of retinoids. So some patients tolerate them very well with minimal side effects. And of course, if it's working, it's very gratifying to know that their skin is improving with the use of retinoids. It's important for us when we recommend retinoid therapy that we know that the individual's health is such that they can tolerate it and tolerate it safely. So one of the important things that we do when we are considering a retinoid therapy is evaluate the individual's liver function and liver health, and at times refer patients for specialized testing to evaluate the liver health. As well, we recommend to minimize alcohol consumption. It's important as well for any women of childbearing age to know to use adequate contraception while on a retinoid. And as well, some individuals, it works quite nicely. Others do experience some dryness of the mucous membrane, so whether that be dryness of the eyes or the lips. And so that is one of the complications of the therapy, are these potential side effects and potential health risks. And we just have a sort of a program to make sure that we're watching for those carefully.
Okay, thank you. And Dr. Hardin did mention about having different therapies available in Canada versus the United States. So it's a perfect timing for our next question, where we're going to talk about treatments. So just recognize that not all treatments are available in Canada and in the US. What are some new treatment options for advanced cases with lesions, plaques, small tumors, and intense itching? And we all know we're always looking for a cure and what's the next best treatment. And as a rare disease, sometimes new treatments can be slow coming. So didn't know if there's any new ones on the horizon either of you have had any experience with.
So I think the question, I guess, is sort of two parts. One is about the symptomatic management of pruritus or itching. And that's an experience that a lot of patients have with mycosis fungoides or even related Sezary syndrome. And it can be very troubling and impact on quality of life. So it's really an excellent question to bring forward, the challenge of itching for our patients. So the first thing is to make sure that there's adequate skin care, so skin health, whether that be proper bathing, cleansing, as well as topical corticosteroids can improve skin itch for some individuals. As well, for people with advanced severe itching, it's important to be on the correct systemic therapy, and we'll maybe get in reserve sort of the details of which systemic therapy would be recommended in that situation a little bit later, but just sort of focus on the supportive care things we can do for individuals with itch. Many patients have benefit using the class of medications from gabapentin or pregabalin are quite helpful, so we'll try those. As well, sometimes people will benefit from antihistamines, and there's some antihistamines that are safe to use and can aid in people sleeping when they have significant itch at night. And maybe I'll just let Dr. Hardin jump in with any additional skin modalities.
Yeah, I think in terms of skin-directed therapy, some of the newer agents that we are getting access to, so in Canada, We previously had very limited access to sort of topical nitrogen mustard and its derivatives, and we now have, it's called mechlorethamine gel. This is widely available in the United States, but more recently has been under review here. And unfortunately, we have access to it only for patients who have private health insurance that can cover it currently. So it's not currently covered under our provincial health plan, but this is one that is an old treatment, but that is new to us. And then there have been some more studies around photodynamic therapy and the use of that also in cutaneous T-cell lymphoma that are still in early phase clinical trials in the United States as well. That's something we're kind of watching out for or looking for, because we maybe would have access to that here also.
Well, it's good to hear that you're getting access to some new treatments in Canada that we've been using here in the States. Our next question, what are the mandatory tests for diagnosing and staging Sezary syndrome? Is a lymph node biopsy necessary when the PET scan shows enlarged and active lymph nodes?
So I can start with this one. So with Sezary syndrome, the most important thing is that you are evaluated by a specialist that is familiar with the diagnosis and knows how to make this diagnosis. It can be very challenging. And since Dr. Hardin and I have been practicing in cutaneous lymphoma, we have encountered many patients that quite likely have had Sezary syndrome for several years prior to meeting us. And it's just been simply too difficult to establish a diagnosis when providers are less familiar with this very rare subtype of skin cancer. So the most important thing is to identify first the skin infiltration. And so the classic textbook pictures of total body erythroderma or redness of the skin. And perhaps many of you who have skin lymphoma have already looked up on the internet what that might look like. And there are a few representative pictures, but that by no means represents how all patients actually present with their skin erythroderma. Many patients with different skin tones or skin colors based on genetics and ethnicity have a different appearance to their skin. It may not be as quite classic bright red as others. So that's where it's really important to have a provider who's familiar with assessing the skin. Many patients might have simply flaking or infiltration or almost swelling of the superficial layers of the skin that we're able to identify. And it may not be as classically total body red, and may also initially not involve the whole body. We've had many patients who present first with redness or infiltration of their skin to their face or upper torso before it becomes all over their body. So the first thing is a really careful skin exam. The next thing that's very challenging is evaluating whether an individual has circulating Sezary syndrome or Sezary cells in the bloodstream. And this requires a specialized test called flow cytometry, and also a very coordinated approach with your laboratory colleagues or pathologists who work in the flow cytometry lab to provide an adequate assessment of the individual blood cells to see if they are Sezary cells or not. It's important to know that patients can have Sezary syndrome without necessarily having an absolute rise in their lymphocyte count as identified on a simple blood count in the lab. Rather, you need the flow cytometry machine or assessment to identify the clone of Sezary cells and then enumerate them to see if an individual meets the criteria for Sezary syndrome. So in summary, I would say that to evaluate or diagnose a patient with Sezary syndrome, you both need an expert skin assessment and an expert blood assessment to establish that diagnosis. I think there was a second part to the question about the use of a PET scan and the necessity for a lymph node biopsy when establishing the diagnosis of Sezary syndrome. I would comment that it's frequent that patients, particularly with new undiagnosed Sezary syndrome, will have enlarged lymph nodes. And in fact, that's one of the sort of triad of an individual with Sezary syndrome, has both lymph node enlargements, red skin, and clonal Sezary cells. I would say, though, that even if identified that they're slightly enlarged, it is not required for the diagnostic criteria to have a lymph node biopsy proving that someone has Sezary syndrome. You would find the same cells in the skin and the blood in the lymph node, but it's not necessary for meeting that diagnosis. So we sometimes do not pursue a biopsy. It's just another medical intervention that isn't required. And similarly, we don't necessarily need to do a bone marrow biopsy to establish the diagnosis of Sezary syndrome. So our approach is to avoid unnecessary tests and just make sure that the tests we are using are effective.
Oops.
Thank you. That was a really wonderful answer. So if we want to go, do you have anything that you wanted to add before we went to the next question, Dr. Hardin?
No, that was excellent.
Okay, I agree. Our next question, I am doing UVB light treatments. My skin gets so scaly and dry and itchy, especially when I increase the time in the light box. Is this normal?
Yes, definitely. And unfortunately, phototherapy is one of our main treatment modalities for skin-directed therapy for early-stage cutaneous T-cell lymphoma. And one of the tricky parts of phototherapy is that it does initially make your skin more dry and itchy. And this is when we really go back to basics in terms of kind of skin health. So what I suggest is bathing every day. And most adults don't like taking a bath, but doing a bath actually is good for the skin. So if you take a 10-minute bath in sort of lukewarm water, and then I call it the soak and smear, where you just get out of the bath and pat yourself dry. You can leave your skin wet and take a very thick kind of cream or ointment-based moisturizer, one that you have to scoop out of a jar and put it all over your body. And then put on some kind of warm, cozy cotton pajamas and go to bed. And this will sort of allow the barrier function and the normal kind of differentiation of the layers of the skin to normalize and help sort of restore moisture to the skin. That phototherapy can often be very drying. So dry, itchy skin is definitely a product of phototherapy. Often as you go, that gets better, especially with some of the tips that I've mentioned. And as I mentioned before, if you're burning after phototherapy or your skin is red beyond 24 hours, then you're getting too much energy. And that can certainly cause dryness and itch in the skin. So just being mindful that you're getting the appropriate dose of phototherapy.
Thank you. Our next question, do you recommend oral supplements for photoprotection to your NBUVB patients? If so, which ones?
So no, I don't typically recommend any oral supplements. There is some emerging evidence more in the like photosensitizing or photosensitive disorders about something called polypodium that I haven't embraced myself. I think I'm not one of the early adopters in this entity. I think overall I want my patients to have a very sort of balanced diet and sort of healthy, active lifestyle. And if they're feeling deplete in some minerals or nutrients, to try to obtain those from healthy eating rather than taking oral supplements.
All right, thank you. So I want to say we're a little over halfway through today's webinar. So if anyone has any questions that they want to get asked, please make sure that you put it in the Q&A box on the webinar. So what do tumors look like? And I know there's a variety, and everybody, what is it? If you've seen one cutaneous lymphoma patient, you've seen one cutaneous lymphoma patient. So I know everybody's can be a little bit different, but is there some broad descriptions of tumors that you can share?
Yeah, I think tumors are ones that you know when you see it. And generally they are, so if we start with patches are flat, meaning if you close your eyes and you run your hands over the skin, you can't feel a patch. A plaque would be an elevated lesion that is often red. It can be scaly. Sometimes it's kind of migrating outward, or it's annular, meaning there's some central clearing. And then tumors are really the lesions that are large. They involve not just the top layers of the skin, but they're going deeper into the dermis and subcutaneous tissue. So they're deep. They can be ulcerated, meaning there's some bleeding or crusting at the top. They can be oozing. They can be painful. They often are very painful and tender, and they generally are more kind of plum colored, a more kind of deep purple or red color. But really, they're deep, they're large, and they can be ulcerated. Is my sort of definition of a tumor.
Okay, thank you. If I get COVID, will it affect my mycosis fungoides?
I'll start, and then Dr. Street, you can add if you have extra. So the Cutaneous Lymphoma Consortium in the US has been collecting their sort of cases of COVID and cutaneous T-cell lymphoma. And I would say that as a rare disease, it's tricky to know which, if there will be sort of a kind of blanket response in people with COVID. I would say overall that the jury's still out. And as the COVID virus changes over time, it's more challenging to sort of make assessments. I think anecdotally, our patients who have experienced COVID have experienced it the same as the general population. And most patients, I think, are responding as would be expected in the general population. So in the early waves of COVID, patients were getting very sick. And more recently, I would say, behaving more kind of typical kind of upper respiratory virus. Being mindful that obviously if you're on different types of treatment for your cutaneous lymphoma, that your immune response might be a little bit different. But that we try in cutaneous lymphoma to have patients on immunomodulatory therapy as opposed to immunosuppressive therapy, in which case their response might not be blunted by their treatments.
Dr. Street, would
I
you
think
like
the
to add
only thing
anything
I have
to
to
that?
add there was about in the early stages of the COVID pandemic, how some individuals weren't able to access their phototherapy. And so some patients had progression of their disease just due to closure of regular facilities that weren't considered crucial medical care. And for that reason, some patients did have advancement of their mycosis fungoides for reasons of the COVID pandemic indirectly. But thankfully now, at least within our jurisdiction, everything's fully operational and not impacted by the COVID pandemic any longer. And in fact, to the best of our abilities, even through the COVID pandemic, Dr. Hardin and I strided towards seeing as many patients in person with appropriate precautions as possible. We tried initially to evaluate some patients by the telephone or other teleconference or video conference, but that is, still somewhat challenging since, of course, intrinsic to the evaluation of cutaneous lymphoma is inspection of the skin. So we for the most part see patients in person.
Okay, thank you so much. So here's one I'm probably going to butcher the pronunciation. Is gemcitabine plus methotrexate a commonly used and effective treatment for advanced stage disease?
I can take this one. So I'll handle it in two parts and then address them together. So methotrexate or low-dose methotrexate, that being either a small oral dose administered on a once-weekly basis or a subcutaneous injection of methotrexate, is a therapy that we use sometimes for cutaneous T-cell lymphoma for an individual who perhaps has progressed through topical therapies or skin-directed phototherapy, or simply unable to access phototherapy for reasons of geography, for example. In our hands, it hasn't always been a very effective therapy, so we generally recommend other treatments like retinoids or interferon, which we haven't spoken of yet today. Methotrexate is also used for patients who have a subtype of cutaneous lymphoma called lymphomatoid papulosis. So if patients have frequent recurrent involvement in areas that are difficult to handle, such as the face, individuals might think about being on a low-dose methotrexate almost as a suppressive or preventative strategy to prevent the development of new lesions. And similarly, we use that sometimes for people with anaplastic large cell lymphoma of the primary cutaneous subtype who have had frequent recurrences of tumors of that type. We will use the low-dose methotrexate. Gemcitabine, on the other hand, gemcitabine monotherapy as a single-agent chemotherapy is a treatment that we use and have funded and available in Canada for advanced stage mycosis fungoides. So this would be an individual who has multifocal tumoral stage MF that has progressed through other therapies, or somebody who has organ involvement of their mycosis fungoides, whether that be lung, liver, kidney, or extensive nodal disease. So gemcitabine generally is our go-to first-line systemic chemotherapy agent in those settings. Although it can be effective initially, one of the challenges with systemic chemotherapy for mycosis fungoides is relapse after discontinuation of the treatment protocol. So for anyone who goes through gemcitabine monotherapy, the full treatment protocol is approximately 4 months in duration, or 4.5 months in duration. And it is common that even if an individual has their MF remit after that particular chemotherapy protocol, unfortunately, it typically relapses within a year after finishing it. So the decisions to start systemic chemotherapy have to be really carefully considered for those reasons. And it's not always the easiest treatment to tolerate as well. I personally have never used the two in combination. I don't know if that's been studied in some jurisdictions, but the two at the same time would be sort of an uncommon systemic therapy. And there would be just overlapping toxicities to take into consideration that would have to be monitored closely, specifically myelosuppression or reduction in blood cell counts. So I think that would be less common that those two are used simultaneously, but maybe in sequence of one another.
All right, thank you very much for that. Our next question, do you consider CT-CTL to be moderately or severely immunocompromised?
I guess the clarification there is, do I consider patients with cutaneous lymphoma to have immunocompromised from their disease? Is that a fair interpretation? Okay. So I'll start and say that, there's such a huge spectrum of disease in patients who have cutaneous T-cell lymphoma. I would say in early stage disease, there is a small kind of immune dysregulation, but I wouldn't consider those patients who are achieving only skin-directed therapy to have a severe immunosuppression. But we know as we get towards more advanced stages of CTCL, and absolutely with Sezary syndrome, there is a shift in the immune balance and the body's ability to regulate sort of normal immune response. So yes, in patients with Sezary syndrome or advanced cutaneous T-cell lymphoma, I would consider them an immunocompromised or deficient state because their immune system isn't functioning normally, and the blood cells that are being produced are not functioning as normal blood cells would in terms of fighting infection. I also would note that patients who have extensive involvement of their skin are at a major sort of potential source of infection because with skin breakdown and barrier dysfunction, the potential for pathogens or infections to come through the skin is much higher. So even from that perspective, yes, I would say there is immunodeficiency because our main barrier towards infection from the skin is impaired.
Okay, thank you. Next
Just
question
to add
is
to
on,
that,
go ahead, Dr. Street.
sorry, I mean, Dr. Hardin gave an excellent answer, but maybe just to provide a couple of illustrative examples for her reference to the specific immune dysfunction that individuals living with Sezary syndrome experience. That actually is a heightened risk of some of the infections that require T cell immunity to protect against. And so specifically those would be reactivation of herpes simplex virus. So some people may experience a lifetime of never knowing that they have dormant within their body the herpes simplex virus. And upon getting Sezary syndrome, because the T cell immunity is impaired, the herpes simplex may activate for the first time, and an individual may develop herpetic lesions in their oral area or genital area. So it's just important to know that that's all about the T cell immune surveillance and doesn't necessarily represent a new infection. As well, the T cell immunity is really crucial to protect against reactivation of shingles virus. So some of our patients are at risk of shingles, and for that reason, we often recommend that they take valacyclovir for shingles prevention, just to avoid that unfortunate circumstance.
What is your experience with mogamulizumab for treatment of Sezary syndrome? How long is the effect of the infusions after stopping, and how long is treatment given?
So I can address that. So we've been very fortunate here in Calgary and Alberta to have access through the new therapy of mogamulizumab for the treatment of advanced mycosis fungoides or Sezary syndrome. So for those in the audience that may not have heard of this particular therapy, it's an antibody directed against a certain chemokine, which is like a chemical signal that tells the tumor cells to migrate to the skin. It's exciting in that it is one of the only drugs to have been tested in a randomized phase 3 clinical trial to help shape our treatment selection for patients living with these diseases. Within Canada, it's gone through a special process to have it recommended for funding in each province across Canada, but there's currently not widespread access to the drug. The company is working on some remediation within their manufacturing, as I understand, but that is soon to be more widely available in the close of 2023. Mogamulizumab is a therapy that we've used quite broadly with great success for our patients living with Sezary syndrome in particular. I think the question was specifically around how long does the remission duration last after stopping the mogamulizumab. So I'll get to that in a moment. Oh, thank you. Someone just popped it back up on the screen for me. Yes. So the protocol for mogamulizumab is to take the infusion once every two weeks. In our experience, patients who've had significant skin involvement with their Sezary syndrome, blood involvement with their Sezary syndrome, and related symptoms have experienced very prompt response with improvement of symptoms and all those clinical parameters within a few cycles of the mogamulizumab. One of the open questions for us as providers that will be answered with further experience and possibly new trials will be, when can you safely reduce that frequency of mogamulizumab to an infusion every 2 weeks to something more achievable long-term, more like a maintenance protocol of mogamulizumab. So we have continued with the protocol that was written in the original clinical trial of every 2 weeks for patients that are able to tolerate that. And we continue it so long as it's working. Dr. Hardin may be able to chime in about her experience through the United States, where some larger cutaneous lymphoma centers have started to look at creating more of a maintenance protocol for the mogamulizumab.
Yeah, definitely when I was away, and the work towards sort of publishing this literature so that it can be sort of more widely used across the world is underway. But again, with only handfuls of patients, and as you can imagine, all the patients that are on mogamulizumab have been treated with many things, and often mogamulizumab is still used concurrently with other treatments, such as extracorporeal photopheresis or interferon. But yes, while I was away, there were centers that were kind of tinkering with reducing frequency of mogamulizumab to every month, or sometimes extending it longer in certain patient circumstances.
All right, thank you so much for that. Our next question, we actually hear kind of often, is how do you advise newly diagnosed patients with CTCL to explain their disease to family and friends? What we hear a lot of is it's cancer, but it's not the cancer that's going to kill me in a month. It's the cancer I'm going to live with the rest of my life. So how do you explain to someone that you have this chronic disease that is cancer?
Yeah, this is a very tricky one in terms of not just explaining it, but understanding it yourself as well, and sort of reconciling what does this mean. We have patients fill out quality of life questionnaire when they come to clinic, and I would say universally the one that scores quite high is I'm worried that my disease will progress or that my disease will get worse, because there is so much uncertainty around a new diagnosis of a type of lymphoma. So one thing that I encourage patients to do, and now that we're back sort of fully operating, is including close family members in visits. So partners, spouses, children can always come and ask questions with the physician, I think is very valuable. I also think the Cutaneous Lymphoma Foundation is an excellent resource, and I direct all my patients to the foundation with a new diagnosis so that they can learn and read about it as well. And then really in terms of how you navigate it with family and how you explain it, I think depends very much on the stage of your presentation and what your own personal understanding is of your disease. That is pretty patient specific, but certainly including close family members in office visits can be useful, and then directing them to excellent resources that we trust, like the Cutaneous Lymphoma Foundation, are useful.
I think just one other small point to add would be, the information we glean through completing the patient quality of life surveys is really quite eye-opening for us. It's important for family members to recognize that the most important aspect about an individual's skin lymphoma may not be the same aspect that's most important for the individual. So, for example, some patients might be worried about their skin symptoms, their feeling of itch or burning, whereas other times they might express that they're nervous about having their skin revealed to other individuals. So whether that be doing their occupation or doing activities that they enjoy. And so I think it's important for family members to understand what the most important priority is at achieving the best quality of life for the patient with the skin lymphoma, more so than necessarily what their perceptions are of the disease.
Great, thank you both for that. So we only have time for a couple more questions. So I think we have this one and we'll have one more. Is there a specific diet to help treat CTCL?
I can start. And the sort of quick answer I would say is not that I'm aware of. As I mentioned already before, is the importance of, I think, maintaining a balanced, healthy, sort of nutritious diet, whatever that looks like to you. I think in terms of our understanding of diet and food and disease in general, I would say is that, we're lacking in terms of the contributions that diet makes. And so this is something that maybe will evolve over time, but to my knowledge, there isn't a specific diet, certainly not a diet that's been studied in skin lymphoma specifically, that would maybe change or alter disease.
Okay, thank you. And this is going to be our last question for today. Can PCALCL move into the lymph nodes? And if so, is it common for the disease to spread quickly throughout the entire lymphatic system?
Yeah, so I can take this one. So the question is related to primary cutaneous anaplastic large cell lymphoma, which is for those who may not be familiar with that, it is a subtype of cutaneous T-cell lymphoma, and it's distinctly separate from what we've been chatting about for the majority of this presentation, being mycosis fungoides. This diagnosis is distinct in its clinical appearance. So most often it presents with a solitary or individual tumor of the skin, or sometimes a cluster or region within one part of the body. It can also, in less common scenarios, present with multiple tumors of the skin in different places of the body all at the same time. The most important thing for us with establishing a diagnosis of primary cutaneous anaplastic large cell lymphoma is first excluding the coexistence of systemic lymphoma. So if an individual at presentation had widespread lymphadenopathy, so pathologically enlarged lymph nodes, along with skin involvement, then that would be categorically systemic anaplastic large cell lymphoma. And the distinction is very important because the treatment is different from an individual who just has primary cutaneous anaplastic large cell lymphoma. If one has widespread disease, then the treatment is systemic with chemotherapy. Whereas if an individual has primary cutaneous anaplastic large cell lymphoma, our primary therapy is radiotherapy. So the other thing is, when an individual first presents with primary cutaneous anaplastic large cell lymphoma, is to check to see if they have coexistence of mycosis fungoides, which interestingly can coexist with this different histology subtype of skin lymphoma. It gets a bit confusing at this point. And the question was pertaining to if someone had lymph nodes at the same time as primary cutaneous large cell lymphoma. And so my comment there would be, you need to be assessed by an expert in the field to make that distinction between the systemic lymphoma or simply the skin lymphoma with regional lymph nodes. So if you had a large tumor, say in your leg, for example, it would be not unexpected to have a swollen lymph node in the groin, which is draining that same leg, in which case it would still be primary cutaneous anaplastic large cell. However, if you had widespread lymph nodes far away from the site of the skin disease, then the likely scenario is that someone has systemic anaplastic large cell lymphoma. There are also some differences that are subtle histologically or under the microscope. So again, that's where having a clinical expert as well as a pathology expert working on your case to make sure that you're recommended to receive the best therapy.
All right, thank you so much for that answer. So before we leave, I wanted to say thank you to Dr. Street and Dr. Hardin for joining us, and I wanted to ask if either of you had any parting thoughts before we sign off.
I just want to express my gratitude to all those attendees for coming and listening, and thanks to the Cutaneous Lymphoma Foundation and Autumn for including us in the webinar today.
Yes, thank you so much. It was exciting to be part of this organization as a couple of Canadians here practicing in the field of cutaneous lymphoma. It's a very rewarding part of our careers to help individuals with this rare but very important subtype of lymphoma. And so I'm pleased to meet you all through this forum and hope that our guidance was helpful, and have yourselves a great day.
Right. And thank you again. And thank you everyone for joining us today. We look forward to seeing you at a future program. And please take the survey that will pop up at the end of this webinar. And thank you again. Have a great rest of your week.